welcome everybody. For those that don't know me, first job, start the recording. Thank you very much, Neil. For those that don't know me, I'm Debbie Loke. I'm the CIO at University Hospitals of Derby and Burton, and also the EPR Director for UHDB and Chesterfield Royal Hospital at this current time. And I'd like to hand over to our two panelists today, Daniel and David, to introduce themselves. Daniel, do you want to go first?
Yeah, thank you very much, Debbie. I'm Daniel Hallen. I am the Chief Information Officer for East Lancashire Hospitals in the North West.
Thank you, Daniel. And David?
Hi there, I'm David Newey. I'm Interim Chief Information Officer at the Royal Marsden.
Thank you, David. So just to remind everyone the way this works, there is a Q&A section. Please ask questions as Daniel and David are going along with their presentation. They've got 30 minutes of discussion time here with us. So I will disappear, David, Daniel, and I'll let you go ahead with your updates around EPRs. Thank you.
Okay, thanks. Just share my screen. Okay, so hopefully we can all see that. I'll just very quickly check before we get started. Okay, so welcome everybody. I think today's session is really important because there's a number of NHS trusts that are going through the starting of EPR implementations, particularly in line with the Frontline Digitisation Fund. And one of the really important things that I think we as a combined organisation need to do is share those lessons so that we're able to improve and make the whole thing slicker, safer and less prone to error. So when I was reflecting on our EPR implementation, really I thought, what's a good analogy that everyone can relate to, whether you've done an EPR before or not? And really I came up with the idea of decorating, and there are actually a considerable amount of synergies between decorating a house and actually doing an EPR implementation. I'll just share those with you. We'll just talk about general principles and then we'll go into perhaps a little bit more detail. But the first thing is you really need to have a clear view of what the room's like currently and where you want to get to. And having that end state in mind is really, really important. The next piece is obviously about getting stakeholders engaged about what the end design looks like. There's no point decorating a room at home to have a partner come in or a family come in and absolutely hate it. You've got to get consensus about what the end state will look like. You need to have a realistic view of how quickly you can do it, and also what do you do during the disruption. So again, if we think about it, is this a 3-month project to decorate a room? Is it a 3-week project? Is it a 3-day project? You really need to have a reasonable sense of time as to how long you think it's going to take. And what you won't generally do is take that view on your own. You'll actually ask the trades that are involved in it as to how long they think it will take. So it's really important to get buy-in to understand how quickly that's going to be achieved and everybody that's going to participate in that. You need to have a budget catering for the what ifs. So again, if we use our decorating analogy, I've done this before. I've drilled through a plaster wall and gone straight through a radiator pipe. Those things happen. And invariably with an EPR implementation, you will find something that you wasn't expecting, and that can be anything from a particular service that hadn't previously been considered. It could be a part of the estate that needs remediating in terms of IT and equipment. It could even be finding asbestos in walls when you're actually putting in network points. So it's really important that you have that contingency budget factored into your EPR business case. The next thing you need to do is, when you're decorating a room, is having all the trades lined up and procured. You need to have gone out and done your soft market testing, you know, had the builders come round, and some might quote you, some might not, but you've got to set out what you want doing. You've got to be very clear about that. And that takes time. And again, you can underestimate the amount of time that it takes in order to get third parties engaged, procured and lined up, in order to make sure that they segue into the correct point in time when you are ready. Just as you need to make sure that your plasterer is lined up to come in after the electrician or the plumber. You've got to have a plan as to when people will arrive and when their dependencies are. And again, that's really, really important that you have very, very good planning and understand the points and the dependencies in order to achieve those real key milestone gateway reviews. It's really, really important that, for example, you know that you've got to build a series of servers in order to create your test environments, in order to test your interfaces. You might have to then do a whole series of UAT around that upgrade of software. So it's all those interdependencies that you may forget about. You've got to go and source and buy the materials. Again, EPR procurements can take up to 2 years to run. And even then, you've still got to think about your third-party peripherals, your interfaces, system upgrades, how you're going to resource it. It's really all those kind of things. It's all in the preparation. And again, that is a very key thing. If you think about decorating, the longest period of time isn't the painting of the room. You can generally do that in a day. It's the masking up. It's putting that the masking tape on the wall, having it peel off, doing it again. All those kind of things, sanding down, washing the walls, taking the light switches off. The preparation actually for an EPR should be a lot longer, years longer, than the actual implementation of the EPR, and it should be thorough. If you go into an EPR poorly prepared, you'll have the same outcome as if you go in to try and decorate a room without all the prereqs done. Things will go wrong. It's guaranteed. It's how you handle them that is really important. Just like at home, you know, it's if you do go through the radiator pipe, how do you handle that? What do you do? And it's your attitude to that and the support that you get from your colleagues that help you get through that. The devil is in the detail with an EPR. It's absolutely key. And just like having an eye for detail when decorating gives you an absolute superb finish, having eye for detail in terms of your test plans, in terms of ensuring that you've got wet ink signatures and things like that, that people are genuinely testing correctly, are testing both positively and negatively. All those things are absolutely essential for a smooth go live. And we'll talk about it in a minute, but you know, making sure that Wi-Fi coverage, for argument's sake, is nailed down. All those kind of things. Measure twice is to measure right, and that is very, very true if you ever do any decorating. If you go and cut a piece of wood and you don't measure twice, invariably you'll cut it short. And what happens in terms of an EPR is it's about continually challenging and continually testing and making sure that the assurance is there in terms of what you're delivering. Buy cheap, buy twice. And this is as true in EPRs as it is of anything else. It's not just the software cost, it's actually the cost of the peripherals, it's the cost of the solutions that you put in. You know, you've got to have that eye for longevity. This equipment that you buy for your EPR go live has not only got to be current when you go live, and you might buy it and have it delivered 6 months before you go live, but then it's got to be fairly substantial in terms of being able to withstand the rigors of a hospital environment and a clinical environment being wiped down, being moved around, being inadvertently pushed into walls or dropped. It's got to have that substantial factor of being able to withstand the environment. Regularly checking in with the stakeholders on the progress. And that's really important, is getting people to come in and go, is this right? Does this look right? So again, if you're decorating, the first thing you'd do is you'd paint a patch of paint, and you would turn around and say, does that look right? You know, is that right in the room? Invariably, it looks different on the tester pot than it actually does on the wall. And it's the same with your EPR build. If you start going in to build a new EPR and start putting in clinic codes, start putting in pharmacy, putting in your list of drugs, your formulary, putting in your order tests, if you're not regularly checking in with all the stakeholders to make sure that they are being correctly input, that you know, you don't leave it weeks before you check, you leave it days or a day before you check. You do that regular checking initially, and then as you build trust and confidence, the checking can come back a little bit. It's all about that initial work that you do and that initial setup. Keep your neighbours informed. This is very, very true if anyone's ever done any work outside the house. And it's very, very true of EPRs. You know, we're working in integrated systems now. This is about keeping your integrated system up to date. It's about keeping the centre up to date. It's about keeping all your sort of partner organisations up to date as to what's happening, what difficulties you're finding, and then when you go live, making sure that you're keeping them informed and in the loop as to how things are going. And the final one, which anybody that's had a trade around their home doing work knows full well, keep them well stocked in tea and coffee. And that is actually applicable to EPRs. It's not just about making sure that people have refreshments, although that is really, really important. But it's about checking in on your staff to make sure about their well-being and making sure that they are coping. EPRs are singly some of the most stressful system deliveries you can ever do in a career. And some people will only ever do them once in a career. Other people will go on and do them several times. But that does have its effect on people, not only at the go live, but actually for many, many months post go live. And it's important that you keep an eye on well-being. So when we approached the EPR implementation at the Marsden, we had some EPR defining principles. And it's really important that you get a charter together as an organisation and set out right the way from chief exec down as to how the entire organisation is going to orientate itself and actually approach this this delivery of this EPR. And there were very, very key guiding principles that we followed as an organisation, which really kept everybody together and moving in the right direction. Building the human network. Now, again, this is in part stakeholder management, yeah, but it's also about establishing the principle that EPR deployments and deliveries are not digitally led. They are clinically and operationally led. Digital is a purely enabler, and I know we say that many times, but it is so important that this is owned by the operation right the way through the organisation, because it is the operation that will have to live with it. It is the operation that will have to train or should train their own staff. And it's also the operation that will have to respond to issues that come out of the build. So it is absolutely important that in the same way clinically we have MDTs, that we have a very rigorous human network that's built out throughout the entire organisation. The data migration, start early. You cannot underemphasize or understate the amount of effort that goes into data migration. So make sure that you've got those subject matter experts engaged early and understand where the overlaps come. Those resources that are going to be doing the building of the code tables in the EPR are going to be doing the testing of the data migration, are going to be doing the testing of the interfaces. Just make sure you understand what those dependencies are and where they come on the plan. And also look at where, for example, your scope of data migration. Are you going back years, months? What is the purpose of the data migration? Is it for clinical records and reference? Are you going to do that through a different method, like a legacy clinical viewer? Or are you going to just use it for bootstrapping future activity? For integration, the key takeaways from that is make sure that you've got sufficient test systems built well in advance. Make sure you've engaged with your third-party suppliers so that they're aligned with your timescales, so that they are able to confirm what versions of software that you are going to be testing against. So you might be on version 4 of a local RIS or LIMS, but actually the supplier might be saying, well, in order to integrate with this EPR, you need to be on version 5. And you need to focus on the fact that you might have to do iterative upgrades to clinical and downstream systems in order to make this work prior to the go live of your main EPR. Make sure you've got a stable build, and make sure you're performing that negative testing. You're not just assuming that things will always be entered correctly, that the data will always be correct in its format. And really make sure that you get those wet ink signatures, not just an email, not just a phone call or a Teams message, a wet ink signature from service leads to say that they're happy with those builds. And finally, make sure your end user devices are performant. We upgraded all our Trust PCs to 16 gig of RAM. It was a cheap upgrade. It made a massive, massive difference to login speeds and performance. Make sure your Wi-Fi, you've got good coverage of Wi-Fi, and make sure that the concurrency on those wireless access points is really low. We aim for about 25 users per wireless access point, but we've seen other trusts that have got way in excess of 100. So it's really important that Wi-Fi and end user devices you pay attention to that. And the final one is make sure you test it to death before you go live. We tested 98%, 99% of every single device across the trust 10 weeks prior to go live. And that resulted in very, very low issues that were raised as a result of that post go live. So that really concludes my talk. I hope you found that interesting. I hope it's inspired you to not only implement EPRs, but maybe go back and look at what rooms need decorating at home. Anyway, thanks very much, everybody.
Thank you very much, David. We're going to hand over to Daniel.
Wonderful, thank you very much. This is where I do the bit of technology and get the screen to share. Now, with a bit of luck, you should all be able to see that. So, good afternoon, everybody. Thank you very much for your time this afternoon, especially on a Friday afternoon. My name is Daniel Hallen. I use the pronouns of he and him, and I'm the Director of Data and Digital and the Chief Information Officer for East Lancashire Hospitals NHS Trust here in the northwest of England. Look sort of like Greater Manchester and keep going up. It's rotten weather out there, so please make sure you take care of yourselves and be safe and healthy. So, in June of this year, the Trust started a major transformation programme by implementing the Electronic Paper Record, or EPR. We went with Cerner Millennium. It's the biggest milestone in our 10-year journey of digital working and was a culmination of nearly 5 years of work from business case to design and build. Today, I'm going to share some of the thoughts and experiences of our journey so far, as we're literally just 4 months in yesterday. So just a little bit of background about our trust. We're a large multi-site teaching hospital trust. We've got sites in both urban and rural settings. We've got some seriously challenging geographies. There's a lot of hills up here, and a population that ranges from the very wealthy and affluent to the disadvantaged and deprived. We've got about 13,500 staff, which is growing every day across acute and community settings. And we've got one of the busiest urgent and emergency care departments in the country. We're also familiar with, we're all, I guess, familiar with the operational pressures across our services, so I probably don't need to go too much into that. And there's never a right time to implement a new EPR, but there's never a wrong time to do it as well. So, you know, if I'm asked if I want to do an EPR again, I'd probably say no right now, because we're still in the thick of it 4 months in. But actually, this is something that's essential for all hospital trusts to have a really good, robust electronic patient record. So in the context of all of that, we're a trust that employs and serves a lot of people. The whole process before and after implementation is a very long and winding road. And I'm sure you all start hearing that little earworm as the day goes on. So there's always a plan at the start of all this. Your supplier will give you, this is the way we've done it approach, and then off you go with approximately 2 years ahead of you. We had about 2.5 years in total around this. So the first thing that sort of kicks in is your process design. You start looking at current and future state. Then you start doing the assessment of what data you need to migrate. How you're going to deliver medication EPMA safely needs mapping out, and that's a big piece of work. You're going to have to consider what technology you're going to need. That always becomes a bit of a question. What systems you need to integrate with may seem like the small thing, but actually is really seriously large, because you've got to still maintain hospital systems and all your external connections. And having a partner that understands integration is the make or break of your success. The how questions start being looked at quite early on. So in all, you're given quite a hefty plan to work through, and you start coordinating the day-to-day implementation piece. Throughout all of this, you are still running a very busy hospital and community service provision. Your emergency department is still running, and there are significant pressures to deliver more service to an ever-growing number of patients. And you're still trying to gather data in amongst all this. You've got all your daily reports that you need to churn out to help you run the hospital, assure commissioners, and most importantly, manage and look after that patient. Pressing stop is not an option. So despite all this, from the moment of go live, you're running into the next steps of the journey, and you take it, it takes real coordination, focus to help, you know, shape how successful that journey is going to be. Keeping a really strong plan at the center, it means you maintain your journey direction. But I'm not saying the plan is the be all and end all, because things will happen. Things will change on a day-to-day pace. So the plan is, you know, part of the step, and we'll get you into a mode of preparation. Having a really good governance structure is always the start. That is robust, clear, and inclusive, and joined up with with a clear organizational structure. So some of the preparation you're going to need to do: processes and procedures. This ranges from how you do a certain thing in the EPR to what happens if you have an outage. So really review all your business continuity. It's a thing that tends to be forgotten, but make sure you review your business continuity. And most importantly, the practical guides of how to do what. So we did look at one point where we had a particularly bad series of weather, a go live, a high volume of emergency patients, and even lightning strikes and flooding to contend with, all in a matter of hours. You know, we were prepared to put out defences on the extremities of the main hospital campus at one point to deflect further activities of the Four Horsemen. Training is complex. You know, the training of 13,500 staff is a really complex proposition. You've got to start the training early enough to deliver to so many people, but you've also got to not start too early that people will forget things before go live, because people do on their daily lives. But post go live, be prepared to revisit to support staff both individually and collectively. So that training just doesn't stop with EPR go live. That continues on, especially if you're taking on new staff, but continues with your existing staff to remind people how to do things correctly and how to do things in the right way. Technology, as David said, you know, network connectivity, equipment, and so much more is important. If, like ELHT, you were transitioning from a largely paper-driven environment to a digital one, then inspect the need to invest in technology and be prepared for the unexpected. Standard models rarely apply in the complex health and care settings. A workstation on wheels might seem to be a solution, but in a busy ED department where there's no room, there can actually be a hindrance. So you have to look at different ways of doing things. Super users and floor walkers are the crux of any go live. These are the people who will essentially support your wider staff, signpost and know exactly what support to give to and whom, and to give to and to whom. Transformations and deployments are really frightening things, and having that support is what makes the world of difference in this. One of the biggest challenges that we had in preparation is to make sure that your users are set up and ready to go. This means making sure they've got the right access and that the system is working for them. So we had a range of access fairs over weeks, both before and through go live, and actually for a good few weeks after go live, and teams of people supporting. but you can still get it wrong for individuals. So just expect, as Dave said, things will go wrong, but that user experience is critical because it will grow and collect, people will talk about things. Finally, downtime is absolutely critical. And while it's important to test your business continuity, what I'm actually talking about is people. That EPR go live period of a few weeks is, and I say this with great humility, is truly exhausting. You've got to be kind to yourself and you've got to try and share the load. You will do incredibly long days and you'll want to be there 24/7. And certainly for myself, I went from the go live, the first part of the go live, right through the night and almost into lunchtime, but recognizing I had to go home at some point. So it's important to have sleep and rest so that you can support those decisions being made safely. So you've got to have a 24/7 approach, but you've also got to be able to hand things over. That being said, preparation circles back to you don't know what you don't know. And hindsight's an absolutely wonderful thing. And you'll reflect back on the things that you've done and you've learned. But if there is one lesson to be learned, go live and post go live is going to be a good few months before you're ready to release that additional support. Now, so like I said, we're 4 months in and we've still got those L plates on. We're still learning. We're still trying to do things. I've spoken to colleagues who are sort of 12, 18 months in. That doesn't go away straight away. So it's the post go live is as equally, or if not more important than the preparation bit that goes up to it. It's easier said than done, but necessary nonetheless. So I could stand here and I could reel off a raft of numbers and statistics about how much technology we put in. And the little video that's playing on the screen will give you some of those stats that we created. And that isn't me that's sort of dotting around the video. The comms person thought they'd try and model it after me, which was rather unamusing. But above all, it's always about the people. The first thing you're going to realize is that your people have the knowledge and tenacity to make your deployment a success, but you're going to need to backfill them to release them from the work that they're doing. You can't expect them to do this on top of their existing work. That's sometimes easier said than done, in fairness. Having close partnership with suppliers and technologists is absolutely critical. We opted for an on-site model, which allows teams to work really close together, those water cooler conversations. I also reached out and harnessed the strength of our Northwest Skills Development Network. Now, each of the regions does have one of these, but the Northwest one's been running for a good long time now. And there's a lot of strong digital leadership amongst colleagues to support our go live. There's something about having, the volunteers from friends and colleagues that can really help bolster your team and can make you realize, actually, we've all done this bit at some point in our careers. The success of any major transformation, particularly in EPR, is never a tech thing. It's absolutely a people thing, and that was driven very much from the start for ELHT. Whole swathes of the organisation need to be involved from day one and know what their role is and how to participate. So having identifiable support teams and floor walkers and mobilising your entire back office to support will absolutely make this a success. We had the entire exec team out on the floor doing a lot of the support and floor walking, and it was I won't say it was fun, but it was exhausting, but it was actually really nice to be out there and about. One of the driving elements of our transformation at ELHT was having everyone involved. Like I say, from the chief exec to catering, from nurse to pharmacist. We have very much what's called an ELHT family approach. And that was clearly demonstrated through the whole period of go live. Something as simple as feeding your staff and having that at the elbow support goes miles in making this a success. The technology is the technology. And there's a whole lot of work that goes into making that fit the organisation that happens behind the scenes. But the people are at the heart of all of this. The staff, the nurses, the doctors, the pharmacists, the catering staff, the admin, the medical secretaries, the comms teams, the booking teams, data and digital teams, and a whole lot more made this a really big success for ELHT. Your, or probably rather our, people are the success story. And I'm really proud to be surrounded by so many great colleagues at East Lancashire Hospitals Trust that made this a success. It's blooming hard work, but you know what? The people are what keep me going throughout this whole thing. So I want to leave you with something that Desmond Tutu has said. Famous for many things, but in amongst them was his explanation of Ubuntu. So those are the technology amongst you will be familiar with the word Ubuntu. But he talks about not existing as human individuals, but being interconnected. And when you connect, you can make change and affect the world. It is always about the people. Thank you.
Thank you so much, Daniel. So we're going to head straight into our Q&A session. We've got a couple of questions already that are coming across in the Q&A chat, and we've got 2 additional people that are going to join us. Just wait for them to join. We've got Andy and Darren, I believe.
Hi there.
Yeah, hi there.
Perfect, thank you. Do you want to introduce yourselves as well?
Sure, yeah, I'm Andy Miner. I'm the Healthcare Practice Director at Egress Group.
And I'm
Thank you,
Darren
Andy.
Goop, CTO at Egress Group.
Perfect, thank you. So the first question we've got in the Q&A panel is, how big do you think your team should be to safely implement an EPR?
I think there's a good answer to that one, if I'm really honest. However big you think your team is going to be and need to be, it needs to be bigger. This is a whole organisation thing, so it's not just about the techs, it's not the techies, it's not just about the data people, it's across the organisation. So for me, 13,500 people.
Yeah, just to follow on from Daniel's point, whatever you think your team is, double it. Whatever the thing, however many devices you think you need, double it. But I think we as the NHS always we try to be frugal, I think, with what we do, because we're conscious of the public purse. But there is no time to be frugal when you're implementing an EPR. You cannot have enough. And when we were planning for the go live, and we had, I think it was, so we're just talking technical floor walkers now, and we'd allowed, I don't know, 10 per site pretty much for 2 weeks thereafter. And we were having big debates about whether that was the number we needed. Did we need more? Did we need less? But I was very, very very much of the opinion, have them, and if you don't need them, you can roll them off. It's better to have too much than too little in this circumstance, because ultimately, if you delay in sorting something out, it affects patient care.
I'll add to that, Debbie, just to say that it's just about our own staff. So we learned very, very quickly that actually the suppliers that we integrate with, particularly the downstream systems, that we I won't say underestimated the length of time we needed people, but what we needed to do was extend a lot of that out. So it was never going to be about 2 or 3 weeks post go live. You're talking months. So expect to have to pay for that and have that extended support.
Thank you. And then we've got a question for all the panelists around your relationships and partnerships with the EPR vendors themselves. And if you could talk a little bit about how productive or challenging you found that with your particular provider. We clearly don't need to name them.
We've worked with a number of the different EPR vendors, and they all have their own styles for project management, delivery, and their own kind of their approach for carrying out implementation and how they expect your teams to be integrated. I think it's really important when you're going through the procurement phase really to try and understand and get a full understanding of what their implementation approach is going to be and how that's going to affect your organization, both in the implementation and post-implementation as well.
Thank you. Any of the other panelists want to answer that?
Yeah, I'll just follow on, really agree with what Darren says. Each supplier, they kind of have their own personalities as well. So it's very not just about the software. Different organizations will have different personalities, and this comes across in their implementation methods as well. So yes, some will drag you through the process, some are more kind of hands-off and more of a software only approach, and they use third parties, consultancies to kind of fill that gap.
Yeah, just coming, as Daniel said earlier on, it's about the people. And I can just say from our implementation, we had great people from all the suppliers actually. And we had, it goes back to being authentic. It's about refocusing everybody on the patient, and everybody from all third-party suppliers were very much aligned with that in mind. So no, we had a very good implementation. And I think the important thing is you've got to be able to be comfortable with having that thrust and parry, not in a contractual disruptive way, but in terms of escalations. You know, if the supplier is saying, we rely on the supplier having done it before in order to steer us away from making similar mistakes. If you've got to rely on them escalating things that they think are going awry and then jumping on it and not dismissing it. But no, I think, you know, we had a very good team from the supplier.
It's, I mean, as I talked about the LHT family briefly, you know, our suppliers were kind of like part of our extended family. I don't know anybody that has a perfect family environment where it's all happy and singy and everything like that along the way. So that, you know, there are always good days, there are always bad days in there as well. So, you know, there can be rough conversations, but there can be really good and positive collegiate conversations. At the end of the day, this always comes down to individual relationships, people, and you know, none of us sit around the table, whether it's commercial, whether it's NHS, none of us sit around the table wanting to do things worse for a patient or for our staff or anything like that. We all have that collective thing that actually we want to get this done, we want to do this right, because there's a lot riding on this from all sides. So there is a sense of just being able to say, you know, let's just get on with this. I won't read out the acronym, but everybody knows it, JFDI. People just sort of used to say, let's just get on with it and do this thing and make sure this is a success.
Thank you. I think going back to the decorating analogy, that tests all family relationships, doesn't it? So, so moving on to our next question then. So when we talk about all stakeholders need to agree the end design, how do you make sure you get a consensus across clinical groups? And we all know how difficult that can be in different specialties. How did you go about that with your programs?
I don't think you will ever get entire consensus because there will always be differences of opinion. I think what you have to do is you have to focus on, certainly as it says in the background here, safe, personal, effective care, which is sort of our motto from an LHT perspective. That's the focus. You have to come down to the saying that is the right way to do it and the correct way to do it. Some of that can be, but we've always done it this way, so why we now have to do this and do it differently? An EPR will bring more work. That is without a shadow of doubt. It makes, most people will be nodding on this at this point on after the attendees. It will create more work for our clinicians. What we've got to do is to find a way of balancing that operational need to do things with the clinical safety needs. So you're never going to get consensus, but what you do need is you need one person to be able to say, right, we've listened to all this, this is the direction of travel. What you can't have is going into it sort of already fighting and then saying, well, no, we're not going to do anything about it, because then that just doesn't engage.
Yeah, I mean, I agree. I think it comes back down to it. It needs to be operationally led. And that is right the way, you know, head of surgery, all the specialties, all the heads of specialties have to chart the course, and it has to be really led from the top down. I think one of the things that's really important is to remove as much variation as much as possible in the design, for a number of reasons. And one of them is really because the more you customize a system, the more likely you are to have issues come upgrades. So that it's really important. You know, there's customization and there's customization. Having bespoke patient pathways that are designed to a particular clinician is probably not a good idea. Having a bespoke work list or something like that to a clinician is absolutely part of the efficiency of driving the design. So I think, you know, but it does have to be clinically led or operationally led.
Thank you. So another question we've got is around benefits management and realization. And there's a lot of people on this call now probably going through a full business case now where they're having to declare their benefits and get that benefits register in place. But how did you manage that? How did you do the benefits management and then the realization of those benefits since you've gone live?
I'm not entirely sure we've got to that point yet, being only 4 months in. We're still in the post-optimization bit. There was There was a whole host of stuff that was talking about how you get benefits out of a digital system. And if you're looking for benefits from a digital and a cost-saving perspective, you're not going to get them. There will be efficiencies in how things are done. But you then start to look at the quality and the patient safety and the staff safety and all the stuff that it benefits how to do your day-to-day job. That's where you end up looking. But so we're not quite there yet. We're still in the post-go live bit. So our measure phase doesn't actually start until early spring. Yeah, I think it's fair to say expect to your benefits to look out over a long-term period. So certainly ours is a 10-year program. We went into this knowing full well that we were not going to achieve this tomorrow. This is going to be something that is the start of our journey. So that we've been quite clear as a trust from the get-go, but that's been a very, very clear mandate from the executive and the board.
So I'm going to go back to the building analogy here. I'm currently planning, having an extension built. You've got to look at, well, what is wrong at the moment? And this again, so this is all in the context of operation, right? The operational lens. It's not digital, this is operational lens. What is not working right now? What inefficiencies have we got? Everybody knows them. And this is why the divisions have to come up with these, because they all know them from the band 3s, the band 4s, right the way up. They all know where it's going wrong. And it's about looking at that inefficiency, looking at, well, if we could do this and do that, actually, we're going to get that. And invariably, that comes back to either a cost saving, an increase in efficiency, and therefore recovery of revenue, or staff cost avoidance, or whatever it might be. That will always come back to it. So it's really important that the stakeholders look in their own areas, are challenged independently, because again, it goes back to measure twice and measure right. You've got to go back and challenge that. The devil is in the detail. Challenge each benefit, and that's down for the program team to do with an executive sponsor, is challenge those benefits. But ultimately, each division should come along with their own benefit profiles and go, well, this is what we can deliver on. And then actually that forms a baseline for your business case.
Question directly for Daniel, if that's all right, Daniel. So 4 months into your journey, are you now able to support all your national reporting requirements? And what tips would you give your BI or information teams with the knowledge that you now know?
Ooh, prickly question. Almost there. I mean, no disrespect when I say this to national teams, you will be given no leeway in terms of reporting. Your reporting is still required. And I say that from somebody that used to work for the national organisation. So yeah, you're in a position where you know what you're doing on your reports right up to the point that you switch your old system off, and then when you get your new system, you can test it all the way through, all the months and years beforehand. But I'm equipped about that. You don't know what you don't know. That's one of the things you don't know on day one, because you suddenly start pulling it in. You go, hang on, that don't quite look right, and that's not doing that. You're also compounded with the fact that it's a new system for the vast majority of your operational staff across the trust. So people might not necessarily do the right thing because they've either forgotten or they kind of go, oh, I can't remember what to do with that bit. So you do have a period of almost correction in the way people, because people will talk, and if somebody goes, well, I found a way of doing it, and it might not be the right way of doing it. So you end up having to unstitch some of that afterwards. We're getting to the point now, actually, 3 or 4 months in, that we are almost to the point of having completed our national reporting set up properly. The one thing I can advise, reach out to, well, there's a couple of people you need to reach out. National teams, absolutely. The people that we report to through SOS, etc., get them involved from the get-go, because that's really, really critical to make sure you can validate and test the stuff as it's happening. That does the data bit, the tech bit behind the doors, if you will. The bit that is also crucial, reach out to your regional team. So in our case, the Northwest team, because they will suddenly start questioning when the report's going to go, hang on, you saw a sudden drop, where's your reporting manager to? Work it through with them and sort of explain, this is what's happening, this is how it's going to do. The other bit that sort of sometimes gets forgotten in the background of all this is your clinical coding, because that, you change a system will have an impact on what you're coding. That then has an impact on your payment bar results and all the sort of stuff that comes through on your income. You need to chase that up really, really quickly, because the longer that comes out, the bigger the income problem is, because you've got to declare it every month. So yeah, it's not an easy journey. And you've got to work very closely with your supplier to make sure that actually you're understanding what the stuff has in the background. But I think we're starting to sort of see a little bit of sunlight through the trees now. Yeah.
Thank you, Daniel. And then a question for both of you. So you've talked a little bit about BAU teams and not standing them down too quickly and making sure you've got the right support post go live. So how much did you need to expand your BAU teams by? And have you taken on more, or have you retained more of the project afterwards? So are you doing more work? Is it just the settling down, or are you kind of in a phase 2 rollout, I suppose?
Yeah, I mean, you definitely need to keep an elevated level of team post go live. I think part of the problem is, again, business cases are generally geared to the minute you're over the go live, you step teams down. That's really not the way to go. We work in complicated systems. Okay, these EPRs are very complicated to build. It doesn't matter how good your build is when you go live. It doesn't matter how much testing you've done, how much training you've done. People will find ways to break it. There will be gaps in it. And it takes a lot of people to work through those issues that are raised in terms of the build and tweaking it and harmonizing it. We're in a very fortunate place in that we're in a stabilization period. 6 months after go live, we've just come out of stabilization. We're now into optimization, but you definitely have to keep that elevated team up. And yeah, there was a significant ramp up of staff in terms of building it. It's slightly different at the Marsden because we share our instance with Great Ormond Street. There is massive power in sharing a EPR instance and an EPR team. These things are expensive. They drain on the public purse. It's really, but they take manpower to sort of keep them up to date. Combined models are the most cost-effective way of doing that. But yeah, you absolutely do need to make sure you maintain that system going forward.
Yeah, we made a decision to so what we call our CXIO team, so the combination of CCIO, all the wonderful IO jobs, CCIO, CPIO, CNIO, and our wider clinical informatics team, they were extracted because the model that we have is they don't do a full-time digital role. They are also clinicians that are jobbing clinicians on a day-to-day basis. So we took them full-time out of their roles to assign to EPR for the almost 3 months, month running up to, or about 3 weeks running up to, and then the period thereafter. We extended a lot of our suppliers out. Our core team, we made a choice as an organisation that preceded my tenure, to actually use a lot of our core team to do this. So a lot of our core team still in place. But as I said, quick before, we still have our L plates on. We are still learning the system. It's only really in this last week, I say it's 4 months yesterday since our go live. We're only really in this last week or so starting to see the volume of work that's been around the EPR starting to taper off slightly. It's still there, but we're starting to see a drop in there. There's no sigh of relief in the organisation, because this is a case of, well, actually, we're now starting to be able to deal with some of the other things that are going through. Change requests will go through. And I think if we make a mistake as an NHS, as a wider NHS, we throw an awful lot into the period up to go live, the little tiny chunk after, and then we sort of go, right, it's done now. And it's a long period. I mean, I'm talking to colleagues that have been sort of just over 12, 13 months out. And they're saying it's only really now that they're starting to get a little bit of breathing space, because you delay everything that you wanted to do to have to go live because you're doing go live. So there's just that mountain of work going on. So yeah, the teams are larger, inevitably so, but there is a bigger demand. And I guess from our perspective, because we went from largely paper to digital, there was that shift around the 24/7 support and what that means. Because you expect to be able to say, I've got a thing that I need to do and I need it doing now because you're now using a digital system. So it's the expectation management that goes in there. Some of that's PR, about saying, well, if you arrange a change request now, it's going to take a little while to be done. It will not be done in 15 minutes. So there's that communication with people as well.
Thank you. Talking a little bit now around business continuity and the challenges you faced pre and post go live. Can you talk a little bit around how you've managed some of those challenges, particularly post go live?
It was one of the first conversations I had when I joined the trust in January. It was about business continuity. And you don't know what you don't know. So there's a whole thing about doing your business continuity plans, and somebody writes it shoved in a cupboard. You need that practical plan about what you've got and what happens on the day. Now we've had I was going to say the opportunity to test our business continuity plan twice since go live. These things happen. It's just part of the course in a busy 24/7 environment. And when I made the comments about the 4 horsemen, at one point we did think, good God, what next? Because it was weather and all external events that was happening at the same time. These things never happen in isolation. But you need to have a clear understanding of business continuity plan. You need to make sure that you regularly review it. I mean, we're going back and reviewing it again as part of a debrief and looking at where we can make things happen. But if there's anything that we've learned in the post-go live bit, the communication bit is central to the whole piece. You need to have that communication with the trust, because what we were finding was, system would go down, and then it was like within 10 minutes, people go, right, what do I do? What do I do? And you were trying to make sure the message to us, you need to almost have structured communications, which we're putting in place now. Structured communications in the same way as the service bridge does with NHS England, that now is NHS Digital, it used to be, that sends that sort of structured communications out so that people can go, you know what, I now need to undo this. Hospital doesn't stop. And the one place that you can test your BCP and make sure it's working is your ED, because they'll know before anybody else what's going on.
Yeah, I mean, look, Daniel's made a spot on point just around communication. And I won't embellish that point because he's made it so perfectly. I think I'll just talk about it from a different angle, which is it's about business continuity tests and planning. Now, the reality of it is that we always do sort of, structured business continuity tests. So we'll pick the time when it's actually the least inconvenient to the organisation. That is wrong. You need to do it when it's the most inconvenient time to the organisation. That's number one. Number two, we always plan for the big bang, it's off. Everyone's in a room, we're all ready for it. No, you need to plan for a gradual outage. What if ED's reported, but it's still working in radiology? Well, actually, half an hour it's not working in radiology, but it's still working in pathology. Oh, that's gone as well. So you need to plan for that and need to practice that. The third one is Daniel's talked about communicating when it's down. What about communicating when it's coming back up? And also restarting. It's a bit like, I keep calling this, it's like pump priming the EPR again. What systems are you now going to start first? What interfaces are you going to now start first that's going to feed others? Have you got a clear in your, it's not just about business continuity procedures for EPR down, it's also continuity procedures for EPR coming back up. How do you re-engage this beast of a machine that needs to be fed from many different angles? So it's often overlooked, and and invariably a trust always ends up with a mandatory business continuity test, as I call them. But it doesn't have to be that way.
I'll add one more thing as well that you touched on there about the bringing services back up. Yeah, absolutely key. You've also got to consider, what do you do with what's happened in the meantime? You know, so if you've been down for an hour, there's a likelihood that quite a number of patients will have been through your ED, the best way in the will of the world, been through your ED and gone. So you kind of go, well, actually, how do we now back record that into your EPR? How do you now back record stuff that's been done on paper for a short period of time? How do you now put that back into your EPR? So there's those considerations that need to go back in, which need to be built into your business continuity plan. And as David says, never ever do it at the most convenient time for the trust. You've got to do it like the 4 horsemen of the apocalypse. When's the worst time to do it? That's when you test it, because that's when it's going to happen. I can assure you, it's always a Friday.
Thank you. And you can probably see we've got so many questions in the Q&A that we're clearly not going to get through. So I just want to ask all 4 of you in 30 seconds each, if there is one big lesson learned from your experience here or other EPR implementations, what would that be that you would want to share with the group?
I'll go first then. Start earlier than you ever think you're going to. Prepare. And obviously, from our point of view, get your data sorted early on.
Thank you.
Yeah, and I would echo that. Quite often we get asked to make technical changes, which materially are easy to make, but without actually understanding how people are affected by those technical changes, it can be quite unsafe to just put into effect.
I wanted to go with don't do it, but that's not the right answer. I think the answer for me is make sure you look after your people. That's the big thing. It is a people thing. It's an operational thing. It is not a digital thing. The digital is just the incidents. So it's your people that you need to look after.
So I suppose my final reflection is the devil is in the detail. Absolutely get into it. Don't be frightened of it. Get into it. It's going to be 1.5 to 2 years of detail. You need to embrace it. The second one really is bring your staff along with you, clinical staff. The way of doing that is being very clear about what's in it for them. You know, start advertising those benefits of what this new technology that is going to really disrupt the hell out of their jobs for 1.5 years. Actually give them be very clear on what the vision is, not just for the organisation, but for them personally.
And then just on the back of that, would you do anything differently now, David? You're going to say everything, aren't you?
It was about staffing. I mean, you cannot have enough staff. And you know, big shout out to my team who were absolutely outstanding. But you know, they really had to make up. 1 FTE made up the work of 2, and that's not sustainable. So just make sure that you've got sufficient capacity, and that's done from the get-go.
Thank you. Okay, that's been a really useful hour, I think, for all of us, learning about some of your EPR implementations and the things we can all learn from them. There's quite a lot of additional questions still, so I'll talk to the team afterwards and look at how we can probably respond to those and get back to people. Otherwise, I just wanted to thank you all for your time and wish you the very best weekend. Hopefully you can get home in the rain and you don't have school closures like I do and roofs collapsing. So stay safe and enjoy your weekend. Thank you very much, everyone.
Thank you, everyone. Have a good weekend.
Thank you.
Oh, bye.